Hello, everybody. I think everyone's mics will be turned off, but if everyone who's comfortable could turn their cameras on, that would be good. Perfect. All right, we'll begin in just a moment. When the screen goes into the presentation, that's when everyone knows that it'll have begun.
Well, whilst we're waiting, I might as well introduce myself and introduce Raj as well. So I'm Dr. Raymond Wen. Good afternoon to everyone. So I'm a GP and I'm the Medical Director of Primary Care Services at Telecare. Dr. Raj Anand is a consultant rheumatologist and pain physician who will be talking to us about pain today. So thank you for joining us. For those of you who don't know who Telecare are or who haven't heard of us yet, we're a leading provider of virtual specialist healthcare services in Australia. We have over 300 registered clinicians across more than 30 specialties, and we conduct over 3,000 consultations each month across the nation. Our mission is to improve access to quality care, particularly for those in rural and remote areas where specialist support can be hard to reach. So one of our key services is about supporting veterans through DVA assessments, providing expert opinions that contribute to compensation claims and impairment ratings. And through our telehealth model, we ensure that veterans, no matter where they are, can access high quality assessments from specialists who understand the unique health challenges faced by those who serve. I see veterans myself in my normal general practice, separate to Telecare, and I also do some of the assessments from a GP point of view at Telecare as well. Dr. Raj Anand, he's a very experienced consultant rheumatologist and pain physician. He's a staff specialist with Dementia Care, Hammond Care and Greenwich Pain Clinic, and he's actively involved in pain research and is an active member working in multiple projects with the Agency of Clinical Innovation in New South Wales, the Australian Pain Society and International Association for the Study of Pain. So I might hand over, I think, Kerry, you might do the RSL kind of side of things. I might hand over to you and then I'll hand over to Raj as well to start the talk.
Thank you, Ray, and welcome to everybody. I wish to acknowledge the traditional custodians of these lands on which we gather and show respect of elders past, present and other Aboriginal people here today. I'd also like to acknowledge the sacrifice and service by veterans, both current and former serving, and I extend this to their families as well. Excuse me. Now I think just a little bit, Ray's already gone into a little bit of detail about Telecare, but just to give you some more information about their services. So they offer multidisciplinary specialist services, evidence-based, professional and justifiable, and how advocates can help. So it's a service there that we can use to help when we're dealing as advocates with our members.
And
Thanks,
Raj.
Kerry.
Yeah.
Sorry, Ben, I interrupted you.
Oh, I just wanted to say, yeah, Dr. Raj, do you want to take it away?
Yep. Just about to. Just wanted to check if the full screen is visible.
Yeah, we see your slides, Raj.
But is it coming as full screen?
It's not in the presenter mode, but
okay, I'm just going to change that to presenter mode if possible. For some reason, sorry, and just one apologies. Try to see if we can get it to presenter mode.
If you press slideshow up the top or the bottom right corner, yeah.
It's not present in Teams. I don't know if that, no, apologies.
It might also be the sheet. Do you have two screens going at once?
Yeah, I
Dr.
have two
Raj?
screens going, so maybe that's
Yeah.
why it's
So
not.
you're gonna need to unclick the share button and then re-click it and share the screen, or which is in
Okay,
presenter mode.
we'll do that.
Don't you love technology, right? It's one of the main reasons why we have facilitators hop online, telehealth kind of coordinators or tech support essentially that hop online with all of our video consults just in case of similar issues like this.
And I think also it doesn't matter how prepared you are, there will always be that thing that will happen that will throw things out. So you get there.
Hopefully this works. Just trying this out. Hope.
Yeah, that's good.
Yep, that's good.
Are you able to see the next slide in advance, or but that's?
No, we're just seeing the title slide. I'm
Okay,
assuming
that's
you've got
good.
an
Maybe I'm
ultra-wide
having a presenter
monitor.
view. So perfect. Sorry, that's perfect. Yeah, welcome everyone, and thank you for joining us today. I'm a pain specialist and rheumatologist, as Raymond had introduced earlier. I was just thinking what to talk about. I've done a lot of talks over the years for GPs and pain specialists and to the community. Before becoming a pain specialist and rheumatologist, I was a general physician. We did see a lot of pain, but at that time, we viewed pain differently. Through my training in medicine, in every specialty, pain is looked very differently, though. As a medical student, we have very little training in pain itself. Over the working experience, we learn a lot more. Today, I thought I would share a little bit about what I've learned about pain and how, also about how the medical profession reviews about pain. Sometimes what I find is there's always a difference between the person experiencing pain and the people treating pain, and what are some of the challenges over there and how to overcome that. I work in a couple of different places. I have moved over from Hammond Care to work at St. Vincent's Public these days, and in a couple of private rooms, including Telecare. No specific disclosures with regards to this talk. So just moving on. To acknowledge the traditional owners of the land on which we meet today, the people of the nation, and pay my respects to the elders past and present, particularly the Gadigal people of the Eora Nation where I'm present today. And also pay my respects and acknowledge the service of the veterans and their families. I usually start off with a story, and once upon a time, and it's a story of not one person, but of the many people have seen over time. Pain, it hurts, doctor, it really hurts. It hurts even more without the medications. It hurts since the day I remember growing pain. They said, now I'm 50, still growing and in pain. Will it ever go away? I can't do it anymore. It's a lump, it's my bulging disc. It hurts everywhere, but don't know where. Pain, it is the inflammation, it's the nerve on my left. It's not in my head, right? My head hurts. I need my life back. My day is filled with nothing. At least the medications keep my dreams alive. I fear the pain and the uncertainty. I continue to fear the bulge and the looming threat. I fear I'll be left in pain with no medication. I'll do anything. I did everything. The tumor is now quiet, but the pain is more active. The sword of death is gone, at least for the moment. The sword of pain still pierces me as I stare the blank walls of emptiness, waiting for the medications to kick in. Waiting for the medications to kick in. These are many statements which many of my pain patients have kind of introduced themselves or have told me during our consults. And I see different people at different ages, both men, women, young, old, middle-aged, different people present or enter into this pain journey at different points. Some with a certain injury, some following a lifelong of activity, and some where there is no particular cause, and many times it starts one day. And some waited, some took a medication, some saw a physio, some went to other specialists, many treatments they undertook, some had injections, and still the pain persisted. Some had scans. A common question I ask usually my doctor colleagues or medical colleagues on which scan shows which person has more pain. Is it the person on the right or person on the left of the screen? I won't go for a poll today. I mean, though there are more changes on the person with the scan on my right hand side. But one of the things what medicine has taught us is that scans and diagnosis does not show pain, and the pain intensity, or how intense the pain is and how much it interferes, is not always proportional to the changes what we notice on the scans. And that's many times caused a lot of confusion on how we manage pain. And this was a study, I mean, just sorry, some of them are very technical, but largely to show a lot of people, even without back pain, when they've scanned normal people's back, by the age of 60, almost 80 to 90% have some of these physical changes. And these changes start in our early 20s. And this particular slide was to show that a lot of normal people do have these changes. And the bigger question is, why do some people have pain and not? And many people, different people cope with pain differently. Some moved on and used different strategies, and some were stressed. Just playing a video from YouTube, which kind of explains pain beautifully. Let's see if it plays and whether we can get the audio through. Can you hear the audio, Raymond or Ben?
No.
Sorry, is there any audio? Just wanted to check.
No audio.
Okay, sure. We'll see if it comes through. If it doesn't, that's okay. I will talk through. Basically, they're saying pain can feel very differently for different people, whether it I mean, one of the things what they're discussing is depending on the duration of the pain. Sometimes if the pain lasts for a few days or weeks, we call that as acute pain. And that's a normal response of the body. Sometimes it's a protective response and is quite helpful. And again, for acute pain, we would say do therapies, but that's physical therapy, rest, heat, sometimes medication. But if the pain lasts for more than 3 months, we call that as chronic pain. Again, the word 3 months is a bit of an arbitrary line. Sometimes it could be more, or sometimes even early in the stage, we feel that these people can develop chronic pain. And again, with chronic pain, one of the bigger difference between acute and chronic pain is in chronic pain, there's no tissue damage compared to acute pain, where there is a correlation between it. We'll go over it in a little bit of detail. No, I'm skipping a few slides there, but I will talk about it, what was in the video, and might forward the link later. You can see that video on YouTube. Coming back to in pain, where does the problem lie is a frequent question. Is it in my body? Is it in the bones? Is it in the muscles? What we would say anatomical. Or is it a pathology? Is there a particular condition? If you're taking back pain, is there a condition like rheumatoid arthritis or ankylosing spondylitis, or what has been going on? And sometimes in the past, when people were not able to find a cause in the body or find a pathology, they did attribute that to the psychology or in the mind. A part of this before before René Descartes, this was in 1664, a person we use quite commonly in pain talks. In the ancient times, pain was thought to be more a curse or something which happened in the clouds, or different interpretations of what pain was. In about 1600s, René Descartes had drawn this picture, kind of saying there's a hollow tube which takes the message of pain from the foot to the brain. And this was even, in fact, before the discovery of nerves. And this kind of changed the way medical professionals started looking at pain. And this particular model works very well when we are treating acute pain, where we try to find a cause of what's causing it. Let's try to fix it. And that fixes the pain. And that kind of has been the basis of research in modern medicine, and that's improved as time has gone. And sometimes even just looking at an image like this itself can trigger a pain, and if you have had previous dental experiences, that can make it much worse. So the brain does play a role in the generation of pain. And to search for a cause, we have different investigations, different specialists, and to fix it, there are different surgeries, but unfortunately, all of those we've realized do not always fix pain. Chronic pain is a completely different thing. It's more to do with the way pain is processed in the nervous system, and that plays a major role in the way pain presents. There are many factors which leads to the generation of pain, and they can be because of whether it's the different life experiences, the exposure to trauma, the way our nervous system is sensitized, the way our emotions are, our understanding, our beliefs, the way we grow up on how we cope with pain. For example, in my wife's family, if someone had pain, they would take Panadol. In my family, we were just told to push on. So different cultures and different families, we all have different ways of how we manage pain. And a combination of all of these finally leads to how each person present with pain. And coming back to how do we manage all of this, do we use medications or do we address other factors? Something we'll look into. As I said, there are many contributors to pain, whether that's the negative childhood experiences, family dysfunctions, and traumatic life events. These are not necessarily the cause, but all of these can contribute to sensitization of the nervous system, which is what contributes to pain. Again, not everyone with these experiences experience pain, but there is a strong correlation, what they've noticed in the generation of pain. And many people do thrive. So how do we work from one spectrum, whether that's post-traumatic stress disorder to post-traumatic thriving? And the meaning of pain becomes a big role, which is something we've noticed quite often. Medical reports or terminologies like osteoarthritis or the word degenerative can evoke different emotions, and these can contribute to enhancing the level of pain. I'm not saying it's the generation, but how we experience it, or when doctors use terminologies like bone on bone, how our brain interprets that can also play a role in the pain perception. Different emotions, whether that's anger, fear, sadness, being in a lot of pain itself can make people sad and unmotivated. Anger and fear are great friends with pain, and pain can fuel either of them. And definitely our lifestyles, whether that's disruption of sleep, lifestyle choices, can all affect the way we deal with pain and the impact it has on our life. As I said, there are different societal, and cultural influences. It's a combination of all of these which leads to the overall experience of pain. And hence in pain clinics, we try to look at the whole person, not just at what's triggering the pain or what is that one single part of the body which is sore, but also looking at what else is happening in that person's life, what else is happening in their social setting, and what's their psychological response, what's the pain experience, and how are they coping with it, what are protective behaviors, what is helpful and what is not helpful. And this is something which is kind of largely changed in the field of pain, is how can we support function and how do we look at the whole person in managing it. Just talking a little bit about what is the different mechanisms of pain. There are different types of pain. The most common is what we call inflammation. The word inflammation means different things to different specialties too. Many times if we get hurt or if we strain our back, people do use the word inflammation. In the context of an acute injury, when we fall or there's a bruise, there's redness, there's swelling, and there is inflammation. That's kind of a protective mechanism. That's inflammation is a part of that healing. So it's a helpful inflammation in that context. It tells that pain is helpful there to tell us not to move, or if you have a fracture to kind of rest to allow it to be healed, or kind of takes the attention. So we seek medical help or rest depending on what is needed. So pain in that context is a helpful thing. It acts as an alarm, and it's a part of the attentive mechanism. And so that's why pain always is very hard to kind of tell our mind, don't think about pain, can be very challenging. Again, as a rheumatologist, we look at inflammation very differently, where when a rheumatologist looks at inflammation, they basically are looking if the body is overreacting, is the immune system being affected, where without a trigger, it overacts, and that particular chemicals it releases is now harming the tissue, whether it's the joints in the context of rheumatoid arthritis, or in certain autoimmune conditions can affect other organs, whether it's the kidneys, the heart, the lung, the skin. So different conditions. The inflammation from in a rheumatologist or an immunologist perspective is different, in which case they look at medications or immunosuppressants to kind of suppress the immune system. We also look at pain in different ways, one of which we call as nociceptive, in which if a pin or we get hurt if a hammer or something accidentally falls on our hand, it triggers a certain nerves in the body, whether it's cold, whether it's heat, whether it's pressure or chemicals. A particular set of nerve endings are activated. These then trigger the nerves, and that message is taken to the brain. It's still not pain at the level of the body. It's still a chemical or an electrical response. What finally becomes pain is a function of the brain which interprets the signal. Sometimes a same response can be painful, or it may not be painful even by activating the same nerve. For example, when people are having a tattoo or acupuncture, they may not even feel the needle, though it might activate the same nerve. That's because the brain might interpret that sensation differently. So activation of the nociceptive nerve or the pain generating nerve, it's usually one of the causes for mechanical pain. Again, there's lots of chemical reactions going there, and this message goes to different parts of the brain. We have a part of the brain which says which part of the body the pain is. There is a part of the brain which makes it unpleasant and kind of says what emotions to add on to that sensation. And there is another pathway of the brain which kind of says, should this come into our attention or should we quieten down? So there is an inbuilt mechanism in the body to kind of quieten down the pain. And if there are any dysfunctions in that pathway, that can also amplify pain. We do use a word called central sensitization, and it's more a mechanism where what shouldn't be felt as pain triggers the pain pathway, or a touch of a feather rather than feeling it as a touch can trigger pain, or when people are having a massage rather than feeling the pressure sensation can feel the pain sensation, and has been noted to be a mechanism in many different pain pathways. And another type of pain is where there is damage to the nerves, and which we call neuropathic, whether that's the pressure on a nerve in the spinal cord, whether it's after an injury, whether it's following conditions like diabetes or other autoimmune conditions, medications, alcohol, different things can directly damage the nerves, whether that's in the outside of our body or whether, in the periphery, or if it is within the spinal cord or the brain. So that type of conditions are called as neuropathic pain, and it sometimes follows the pathway of the nerve involved. And there is the third type of pain, which is the nociplastic pain, which is where what shouldn't trigger the pain pathway start triggering the pain pathway, like a movement, just sitting on the chair shouldn't normally trigger pain, but the nerves can become sensitized, and a new terminology is being used to describe that pain, which is called nociplastic. And sometimes there's not one mechanism, different mechanisms can trigger the pain. And it's important to know so that we can address the treatment based on what is triggering this pain. There also another way of looking at pain is it coming from the musculoskeletal system? Is it coming from the joints and muscles? In which case, it's more likely to be what we call nociceptive, where it triggers that nociceptive nerve pathways, or is it because of the nerve sensitization? There could also be a small element of inflammation when we're looking at. Once again, a lot of x-rays also do not show pain. This is an x-ray of the knee. Sometimes there is no joint space. Many people, as we keep aging, have these changes, but the body sometimes adapts to these changes. Many times they happen over a long period of time and may not necessarily trigger any pain pathway. So quite often we see that there is a huge discordance, or there's no relationship between the changes we see on x-rays and the degree or the intensity of pain a person feels. Another type of pain from mechanism is what we call a visceral pain. That's the organs, whether that's pain in the stomach, whether that's the headaches, whether it's heart attack, that activates a different system. The internal organs of our body do not have a direct nerve supply. No one is designed to know where the stomach is or where the heart is, but the nerves from those organs through autonomic nerves join at different parts in our spinal cord, and hence present pain. Like when people have a heart attack, they can feel the pain running down the left side of the hand or into the neck, or stomach pain can be felt in the upper part of the stomach, and that's because that's where the nerves join the spinal cord. And many times these sort of pains can be associated with symptoms like our heart racing, feeling nauseous, and affecting our bladder function or bowel function too. Usually the sympathetic nervous system is activated, and sometimes when people have had pain for a long time, people can have other dysfunctions of their body, whether that's the heart or the stomach, which can present either as increased movement in the form of diarrhea or ongoing nausea, or vomiting sensation, a bit of flu-like symptoms could be other manifestations. And pain, sleep, mood all run through the same parts of the brain. So if one is affected, other parts are affected too. Just take a moment here before we move on to how do we manage pain. Do not know if there's any questions or anything, or happy to take any questions at this moment. And if you need to change any directions on what we're talking, happy to do that too.
So feel free to put in the chat if you've got a question. Otherwise, raise your hand on the Teams, the hand symbol. Otherwise, we'll give it a couple of minutes or a minute, let's say. If there's no further questions, we can certainly keep going onto the management side, which I'm sure we are all keenly waiting to hear about as well. So I don't see any hands up at this stage.
I will continue, and happy for anyone to raise it, and we'll review that as we go. Coming back to management, I think the most important thing I've always found is finding a team, someone you can talk to about it, and also finding a health professional who can kind of explain what are possible causes. Sometimes it's easy, or one can say after a blood test or after a scan, we can say this is what is the most likely contributor to the pain. Many times it's not so straightforward, or it's always somewhere in the gray zone, could be contributing or may not be a role. And again, there's always a lot of uncertainty, even from medical professionals, on how they manage a certain scan or an X-ray. And some might say, don't do a surgery. Some might say, do a surgery. Many times with management of pain, there's always this gray zone, because until we've done a certain treatment, it's hard to say, is that treatment going to be effective? In the sense, it's very hard to kind of predict with full confidence on what aspect and how pain, what is the response of that particular treatment for pain. Some treatments are reversible, in the sense it might be taking a medication or an injection. Some of them, like a surgery, we are not able to reverse that procedure. So there's a lot of decision making. So I think it always becomes important to have a good team across, and that might include a health professional like your GP, and also having a good allied health support from a physiotherapist or a psychologist, occupational therapist, exercise physiologist, depending on who is available, and someone who can look at beyond the part of pain, looking at the whole person, and just finding different opinions sometimes can help in the overall management. And just saying all is well is also not helpful. I mean, words alone do not fix pain, though talking about it does help. But kind of looking at it and finding a helpful team is what I feel becomes a very important part. Kind of understanding what could be possible mechanisms. I mean, is it the triggering of the nociceptive nerves? Is it nociplastic, in the sense, is it an alteration of that pain processing pathway, or is there something else going on there which is leading to this maintaining the pain, so that they can direct the treatment accordingly? And also important, making sure we have a regular activity regimen, whether it's a regular exercise or even just daily movements. Having a structure can be helpful. Making sure we have a healthy diet. The value of diet in pain has been recognized, but there's no one prescribed diet. I mean, a healthy, balanced diet is what we would recommend. Different people try different things, from reducing the gluten, reducing the dairy, but again, it's a personal choice, and every person responds differently. I mean, reducing processed food is definitely helpful. Drinking plenty of water. Depending on each person's cardiovascular state, whether they need, some people need less salt if they have more heart conditions or kidney conditions. And some of my younger patients might have to increase their salt intake if their blood pressure is low. So again, that's an individualized recommendations, but trying to keep a healthy routine despite pain and finding that baseline which does not affect the level of pain becomes helpful. If we exercise too much, that can also be a contributor to pain. At the same time, not moving at all can also be a part of that pain generation, because many times there can be what we call a neuromuscular irritability, like what shouldn't trigger pain starts triggering pain, but it does not mean there is damage, but it kind of triggers the pain receptors and pain response. Again, trying to find out what is that level, like is walking for 5 minutes kind of more manageable, where if you sit down for another 5 or 10 minutes, the pain eases, then that's probably the right amount within 15 to 20 minutes. If the pain settles, then that's the right amount. But if the pain persists for a whole day or the next day, then we need to look at, do we need to alter that level of activity? Sometimes we use a word called pacing after each activity to take a break, not because of pain, but because it's 5 minutes, it's 10 minutes to reduce that irritability. And again, education becomes important. And this is looking at, I mean, this is one of the models which a lot of the pain doctors and psychologists use, identifying what's triggering this pain, what's the level of activity, are we doing too much activity, too little activity, what are those thoughts which are helpful and what's not helpful, what treatments are working, what treatments are not working, and what's the side effect of these different medications, whether that's pain medications, medications to help us sleep. And again, what other stresses are going on in each person's life. All of this contributes to the experience. So trying to look at it a bit more holistic, looking at everything going on helps to design a good management plan. And people talk a lot, I mean, in the sense, in the pain programs, which is done in most major teaching hospitals, one of the things they do look at is different ways to understand the pain, retrain the way our mind interprets these signals. Again, it's a long process. For some people, it works more quicker. It all depends on what contribution is coming from the body, how much the nerves are getting triggered, and what other factors are playing there. It's used quite often in complex regional pain, where they use things like mirror therapy to kind of retrain the brain, sometimes in phantom limb syndrome, where people have lost a limb or leg. People use mirror therapies to kind of retrain that pathways in the brain to kind of reduce the pain sensitization. Or how do we replace an unhelpful thought or emotion with a more helpful thought? Again, starts by recognizing some of these sensations earlier does help in managing pain. And there are many online pain programs. One of it is This Way Up, which is run through St. Vincent's program. And again, these are available. If you get your doctor to prescribe, the cost can be waived, or your GP or pain specialist can prescribe. There are many other programs, similar programs too, which can kind of are there. I think Open Arms does have a pain program in person too. And again, identifying what are other contributors, and sometimes they may not be directly visible in the sense there's definitely pain, but the way we cope could also be a factor, whether that's excessive smoking, alcohol, lifestyle habits, too much rest, or too much treatment too. If someone is having too many surgeries or going to the physio every day for a massage, can also sometimes be a part of that pain generation process. And coming back to the main thing, many times we've asked this question: should we put pain medications in the water supply? Will it fix everyone's pain? Unfortunately, it doesn't. And in some countries, they have tried it, like in the States. Some of the common medications we use, the most common one is paracetamol or Panadol. We still don't know exactly how it works. We speculate it works on what's called the COX-3 mechanism, which is present in the brain, but we do not know its exact effect. People have done different studies on paracetamol. For some people, it works well, and it's almost a 50-50 response. We're not able to identify why some people respond better than others. Among all the different medications, when taken in normal doses is safe, but there are risks when overdone. It can affect the liver, or when people are taking it for a long period of time, or for other reasons. If the liver is affected, we would be cautious about using medications like Panadol or paracetamol. And also paracetamol is present in many different forms, like cough medications, Panadine. So being aware, many times it's not mentioned on the packet, or on the label. So looking to see, is it there, can be helpful, so we don't overdose on it. The other group of medications are the anti-inflammatories, such as Nurofen, Voltaren, Naproxen, Celebrex, Meloxicam. Again, there is these work on the peripheral pathways, though they're called anti-inflammatories. They work on a certain mechanism, and they can be helpful. And then there are three major types of nerve medication groups people try. One of them is gabapentin or pregabalin, Lyrica or Neurontin are trade names. Again, each of these medications have their own side effect. We do know some of the side effects with medications like Lyrica, or people can get used to it, can affect mood, weight gain, it can affect the finer or higher functioning of the brain. It can slow people, increase risk of falls. So that's something we are aware of. And again, seeing, is it helpful, and and always reviewing every 3 to 6 months on what's the value of these medications. Is it still effective, or do we change it, is something to keep reviewing. Amitriptyline or NDEP, nortriptyline, is another commonly used medication, nerve medication, can help a bit with sleep. Again, we do in pain medicine, we use it at the lower doses. The same medication at a higher dose can be used for management of mood. The other commonly used medication is an SNRI, which is duloxetine or venlafaxine. Again, they can help a bit with mood and pain. All of these are not perfect medications. Again, even in studies or research studies, it helps. Like, for example, duloxetine reduces the pain by 30% in 1 in 7 patients who take it. So not everyone get these response. Everyone may get a little bit of response, or there may be adverse effects. So each of these need to be individualized in the management. Another commonly used medication on my left is the opioid and the cannabis. That's kind of a more recent introduction. The opioids have been used for a long period of time in different forms, in different preparations, and there's been a general movement away from different opioids, especially as there's been increased risk of harm and dependency and addiction. A lot of people still continue to have these harms, including death. The biggest risk with opioids is the effect it has on the respiratory system. This is an old slide. The data is showing things have reduced, or it's coming downward, particularly since the increased change in regulations. There's a lot of changes, especially in the last few years, starting with Panadine not being available over the counter. And these days, if anyone is on opioid medications for more than 12 months, your doctor would need to get another doctor to review it. So there's more regulation around these medications. And if you're beyond a certain dose, they might have to get authority from the state pharmaceutical services and prescription. And one of this is the harms from opioids are definitely more aware, whether that's immediate in the form of nausea, vomiting, constipation, suppressing the breathing centers is a big issue, particularly when we are unwell due to another cause, or when taken along with medications like Valium or alprazolam, sedatives like gabapentin. All of this increase that risk by almost 15 times. So being aware of the different medications which can increase the harm of opioid medications. And people do become tolerant to it, and it has also been noted to be becoming a part of the pain generation, in the sense it changes the chemical receptors at the level of the cell, so the body stops responding to it, or sometimes it can become a part of the pain generation process. So that's why we try to keep the opioid levels these days to the lower level. I mean, opioids do have a role. I mean, it is helpful for many people as a crutch to move forward. But again, it's about finding where is its right role. How do we keep it to the lowest? And how can we give our body a break from these when possible? So these are all things. And again, a very individual decision needs to be made. In my own experience with different people, some people have been on high doses of opioids. They've been able to stop it, and they feel the pain is still the same, but they're able to manage better even without these medications. For some people, even reducing by a very small amount has made their function go backward. So each person kind of trying to work out and see what's the response of the body and how can we gradually reduce it, has allowed many people to kind of come or reduce the dose of these medications without affecting the pain, without affecting the function or the ability to do their daily tasks and living, and reduce the side effects of these medications. Cannabis is something which, I mean, humans have been using it for a long time. The risks and harms are continuing to be debated. In some ways, from the medical community, we are yet to keep up with the knowledge. We are learning a lot more from use. Is it have much benefit, particularly in pain? It's still unclear. A lot of the pain societies across the world have not yet endorsed the use. I mean, some of the reasons is when they have looked at it in studies, they've not been able to show the effectiveness, and it does help people's pain. And just my general response, it's helped more with kind of helping a bit with sleep, taking people's mind away from pain. For some people, it's allowed them to kind of reduce the use of opioids or benzodiazepines. So there are positives, but again, some of the negatives of cannabis, which we are still trying to, from a medical community, to see what is the longer term risks of these medications. We have a lot of data from illicit use or recreational use, and more data is coming even from medicinal cannabis use. We do find whether we smoke or vape medicinal cannabis, there's still effects on the heart and the lung. That's something. There are emerging trends. There are from different studies is what effect it has on our cardiovascular system. The effect it has on general functioning, especially in people younger, in teenagers and people less than 21 to 25. The effect it has on the growing brain is something which a lot of people are concerned about. Again, it's a helpful tool, I find in some of them, but finding that balance and kind of working and discussing that with each person. Some limitations still include driving restrictions. Though the effect doesn't last long, THC can be present in the body for many weeks or up to 9-10 days. So I think the legal authorities are yet to come up on what the effects are. And so there are some limitations with regards to the use of cannabis. And again, there are dependence and addictions are similar to what it can happen with the opioids in some ways. And again, if someone has a risk or family history of psychosis or mental health conditions, definitely check with your doctors, and there could be a slight risk of decompensation. Once again, this was something from opioids or cannabinoids. It's not about restricting access, but kind of making sure these medications are used appropriately. And again, finding a local team who can monitor that, and somebody who can work with you can be helpful. And each medicine have their own side effects, and how do we work through it is something to look at. Just briefly touching on what are other things people do. People do injections sometimes, whether we call that as joint blocks, where people either inject steroids, some of the pictures on the screen, some into the sacroiliac joint, the one on the red line, or into what they call the facet joints, and knee joint, shoulder joints, different regions of pain, sometimes to nerve block. They put a little bit of local anesthetic and steroids. People inject things like PRP, glucose. Again, the evidence for many of these remain largely unknown, and at best works for a few months. Many of these are more helpful to break sometimes the process of pain and allow people to rehabilitate or participate in physiotherapy or hydrotherapy. So in that context, it can be helpful sometimes to find out, is that the primary contributor from a pain point of view? So people use injections to sometimes as a diagnostic procedure. And people can inject steroids sometimes into the neuroforamina or into the epidural spaces. Some of the risks of that is the effect of steroid itself. Steroids can affect our adrenal systems. Steroids are quite harmful in many ways. So there's a general tendency these days to move away from it, in the sense every injection can leave a lifetime impact on our bones, the most common being osteoporosis and other things. It doesn't happen with a single injection, but each injection adds on to that risk. So again, weighing what's the risks of those procedures. Another thing which pain interventions do is what we call neuromodulation. It's done in different ways. It's been done for a long period of time, and sometimes even dating back to thousands of years ago, where people would use the electric eel in the management of pain. And in a similar way, people use different electrical and heat currents to modulate the nerve. A common procedure is radio frequency, where they burn the nerve fibers. Certain nerves can be burnt, which do not have a sensory response. Or sometimes if we don't burn them, we can modify them with what we call a pulsed radio frequency. People use different techniques. Some people use chemicals to achieve a similar process, different ways to modulate the nerve. People use things like stimulators again. There's a lot of talks about where the value is and the harm is. Again, having a right team to support it becomes helpful. Many of this was designed based on the pacemaker technology. And again, doesn't fix all pain. For certain conditions can be an option. This is again just an image of where they place an electrode in the back of the spinal cord in a space called the epidural space, and it's connected to a generator. Again, reviewing through what the values are. Again, some of them have many years of relief, and then there are many people who do not get that amount of relief. There are developing more newer technologies. This is a system where it's placed outside the back for mainly lower back, where it activates the muscles, kind of used in people who find it challenging to do exercise. So this activates the muscles for 30 minutes twice a day without moving, and just as a way to help kickstart the process against pain. So there's a lot of different technology coming up. In pain, again, from evidence point of view, it's quite challenging. And there's a strong placebo response too. So finding what's helpful can be a bit hard. And just the way in the medical community, pain has, the definition of pain changed in 2020, about 5 years ago. Kind of reasonably similar things. The one big change was instead of tissue damage was always associated with pain. I think one of the things is to have pain. You don't have, someone does not need to demonstrate tissue damage. If it resembles, or if the person says they are in pain, they are in pain. And there are many contributors for pain. It's not always from the nerves or the nociceptors or the pain fibers. Many reasons in this generation of pain. As a treating profession, one has to look at all aspects of pain, what's happening within the body, what's the response of that pain in the person's life, and that becomes important. And everybody can communicate it differently. And pain, the other reason to change the definition is in the past, the patient had to demonstrate that experience or describe that experience. That's why, and in people who are not able to communicate, or people with dementia, or children, or infants, or even animals, they don't need to describe it. So that's why the word resemble has been added on. Even with the way people behave or respond to it can also indicate pain and to be looked at. Stop here for a moment. I think we're almost running close to the end of time too. If there's any more questions or anything.
If anyone's got questions, again, please feel free to put your hand up or use the chat function or the Q&A function. I'll be monitoring both. Raj, there's a question about whether we can receive your slides. Are you happy for that to be shared?
Yes, yes, I'm happy to share them, hopefully, and the video link too.
Yes, that will be great. If you could send that to Ben, then we'll coordinate sending that to everyone. Any other questions?
Or if you want to share your experience, happy to hear that too.
So Wangaratta RSL have their hand up. Yeah, feel free to unmute yourself. You're still on mute, Wangaratta.
Unmute them.
Still on mute at the moment. Yeah. I've put allow mic. It should be able to be. We cannot unmute. Okay. Feel free to. Let me see.
Is it more system-wide?
System-wide. I've allowed unmute for Wangaratta, so I'm not sure why. Maybe we might have to type in the chat then.
Hello.
Oh yes, we can hear you now. Yes.
Apologies, I'm not that computer literate. I actually sent the question in as a chat. Just wanting to know the online chronic pain program from St Vincent's. What would be the cost, and is a referral required?
Yep, I think someone has answered in the chat system. Sorry, I can see the chat system. It is there is a cost of $59, but if your GP prescribes or if your healthcare provider registers for it, they can waive that fees off. It usually you have a 3-month module. Any practitioner can register. I mean, whether it's your physiotherapist or psychologist, any treating professional can register as a provider, and I think they do. They are able to waive that fees. Otherwise, it's $59 for that cost.
Okay, thank you.
I've shared in the chat also the like a screenshot of my portal there. I've registered a little while ago, and I think the main thing is that the GP or the clinician, whoever it may be, needs to register on the portal to be able to prescribe that and have the fee waived. So it's important to let them know about that.
And they do have other good programs as a part of it. I think they've done one on sleep, mood, mindfulness. There are different activities where they do. I'll have to check up. I know Concord Hospital do have a special program for veterans and do a special program, a multidisciplinary program and assessment. That could be another resource to look at. Many, I mean, at least in New South Wales, most regions are connected to one of the major hospitals in Sydney or Newcastle, or to one of the major tertiary pain units, so people can access telehealth appointments. Though I do see that there is difficult access in different parts of the country, like whether that's Tasmania or people in Queensland can find it challenging to find their local team. Or the local teams may not have all the specialists as a part of their pain service.
Any other questions?
Yep, I think Robert has mentioned the National Centre for Veteran Health.
Yes, yes.
Just to conclude something which I had written about pain in my back, 2 sides to the back, my view and your view. Pain in my back. I know it from a long time back. Can't move, can't sit, can't sleep, can't start, can't stop, can't be still. Pain in my back. Where are you in the back, in the joint, in the nerve, in the muscle, in the memory, or in my mind? Pain in my back. How to get you out of my back? Is it a pill, a needle, a massage, a stretch, a few screws to hold my back, or leads in my spine? Pain in my back. When are you going back, so I can get my life back without worrying about my back? The other person, pain in your back. I know you from a long time back, nociceptive, neuropathic, or nociplastic. You may be pain in your back. Where are you in the back? Anatomical, pathological, physiological, or psychological? You may hide pain in your back. How to get you out of the back? Pharmacological, physical, psychological, interventional, or surgery you may need. Pain in your back. When is it going back? Not until the socio-psycho-biomedical and spiritual needs are looked into. Pain in my back, 2 sides to the back, me and my back. Look and listen to me, my story, my back, and realize pain in my back. Just found a 3rd side. Don't forget the context, what else is happening in life: compensation, injustice, invalidation, insecurities, my mother's tumor, my trauma, my midnight TikTok education. Pain in my back, many sides to the back, me and my back. I hope you have my back. Thank you.
Thanks, Raj. I really love that you're such a poet. I love that poem. Amazing stuff. Amazing stuff.
Just stop sharing, or maybe it stopped.
Yeah.
Perfect.
Yeah, you've. I think that poem is a good one to kind of jog the memory about all the different causes, all the different treatments, and also biopsychosocial and spiritual. I think is really important. I just recently did some dual diagnosis training, and I think it's similar concepts that it's the whole person, and other impacts can really influence pain and pain perception and pain management. if we've got no final questions, I'd just like to say thanks to Raj for Dr. Raj Anand for speaking to us about chronic pain today, and or more general pain management, because as we all know, due to the nature of the role, veterans who have served definitely are at increased risk of having chronic pain, and I certainly see that in the patients that I see. If there's any final questions that you kind of think of after this session, just please feel free to send it through. I think Ben is mainly the one who's been coordinating this, or Sandrine as well. That can kind of reach both me and Raj. So thank you all for attending today. Any final things before we finish up?
We're going to be doing another information session next month, I think on the 23rd, and it's going to be on the different types of conditions that veterans will commonly face, and the kind of finer points of what distinguishes them from each other from a statements of principles point of view. But otherwise, that's about it. And I'll get in contact with everyone about that.
Thanks, Ben.
All right.
And if there's any topic suggestions, please feel free to shoot it to Ben, and I will try and source the appropriate speakers.
Perfect.
All right.
Bye-bye.
All right. Have a great afternoon. Give you back all 5 minutes.
Thank you.
Thank you, everybody.
Thanks so much. Thanks, Kerry.